Welcome, everyone. We will start in a bit less than a minute. So good morning, good afternoon, or good evening, based on where you're joining us from today, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization, where we provide stroke education to healthcare professionals worldwide. Now, it is with great pleasure that we are hosting this educational activity today on when infection meets infarction, navigating CNS infections and stroke. We have exceptional speakers who will be sharing their expertise on the topic. But as usual, we will first have a quick look at some of our housekeeping rules for today's webinar. We always welcome any questions you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. So Q&A and not chat for the questions, please. They will be addressed in the end during the Q&A discussion. You can, of course, use the chat box if you want to say hi, tell us where you're joining us from today, or leave any comments throughout the webinar. Also, a reminder that there will be one poll that we ask you to participate in at the beginning to share your awareness on today's topic. The webinar is recorded, as always, and the recording link will be sent out to all of you via email shortly after the webinar, and it will also be uploaded on our YouTube channel and our Academy and WSO websites, so you will be able to rewatch all of the lectures. And lastly, we kindly invite you to fill in the evaluation survey that will pop up on your screen at the end of the webinar, which will also allow you to share your feedback, of course, but also download and claim your certificate of attendance. Now, without further ado, let me introduce today's chair, but also our moderator, our World Stroke Organization President, Professor Jeyaraj Pandian. Professor Pandian, thank you for being with us today, and the floor is all yours.
Yeah, thank you, Laura, and welcome everyone for this important and interesting webinar. We all know the global burden of stroke. It's one of the leading causes of death and disability in the world, and particularly in low and middle income countries, stroke occurs at a younger age, and many of the population-based studies have shown that stroke in the young, it is there's a high proportion in these countries. We know the typical vascular risk factors, hypertension, diabetes, hyperlipidemia, obesity, smoking, alcohol. So we know these traditional risk factors, and 80 to 90% of the strokes occur because of these causes. However, there are several common and uncommon etiologies for stroke with the regional variations, geographical variation, and particularly CNS infection and stroke. And this particular webinar, we will explore the complex intersection between the central nervous system infections and stroke. We have taken some of the common CNS infection and also some uncommon CNS infection for us to learn and also be aware. In this era of climate change and also easy international travel, there is a potential for some of these infections spreading through these travel. We know about COVID-19 and how it had impacted globally. Many of these conditions have typical presentations, clinical presentation, and radiological findings, and also the treatments are different. And with this, I will open this poll. Laura, you want to post the poll? I request the participant to complete this, and then I will introduce the first speaker and the first topic.
So we are asking you, how would you rate your current awareness of the link between central nervous system infections and stroke? I am not aware, I am slightly aware, somewhat aware, and very aware. You have another 15 seconds to vote.
Okay, yeah, somewhat aware, slightly aware. So I think this is going to be a very important webinar. Only 25% are very aware. So we have a big group of people who would like to learn and update themselves. And so it's my pleasure to introduce Dr. Vinita Daniel. She's an additional professor of neurology. Laura, the introductory slide is there.
Vinita will be sharing directly her
Yeah,
screen.
okay, yeah. So she's an additional professor of neurology at one of the premier institutions of from India in the city called Lucknow, Sanjay Gandhi Institute of Medical Education and Research. This particular center over the last 2 decades, I would say, has done tremendous work and research in the area of TB and stroke, and also the different manifestation of CNS tuberculosis. And Dr. Vinita is a senior faculty from this institution, and she will talk to us about stroke and CNS tuberculosis, a hidden threat in tuberculous meningitis. Over to Dr. Vinita.
Thank you, sir. Good evening, everybody. Thank you, sir, for the kind introduction. At the outset, I'd like to thank Dr. Jeyaraj Pandian and the organizers of the World Stroke Academy for giving me this opportunity to share our experience on stroke in tuberculous meningitis. And stroke is definitely a hidden threat in tuberculous meningitis. We'll be going through a short introduction, then learning through a case study, and then going on to stroke in tuberculosis, seeing the magnitude of the problem, and then the clinical features, the neuroimaging features, and the prognosis. Stroke and CNS tuberculosis are both major causes of mortality and morbidity all over the world. The World Stroke The World Stroke Organization said that 1 in 4 adults over the age of 25 will have a stroke sometime in their life. Now, strokes may be ischemic or hemorrhagic. Most of the strokes associated with CNS infections are ischemic, though there have been reports of hemorrhages and venous infarctions as well. Coming to tuberculous meningitis, the WHO estimates 100 million new TB cases every year. So it is a very great problem in endemic countries, especially in India, with 1.5 million deaths every year from tuberculosis. And tuberculous meningitis constitutes approximately 1 to 10% of TB cases, depending upon the endemicity. So by approximating, we can say that there are around 100,000 tuberculous meningitis patients diagnosed every year. That's a large quantity. That's a large number. Tuberculous meningitis is the most severe extrapulmonary form of tuberculosis, and it is a subacute to chronic meningitis. Patients present with vague malaise, appetite, and weight loss, with evening rise in temperature and night sweats, just like classic tuberculosis. It is later in the disease that patients develop the signs of meningitis with fever, headache, and neck stiffness. A history of TB contact is elicited in less than 10% of the cases. When we look at the clinical staging of patients, when they come to us in the emergency with TB meningitis, we are using the modified British Medical Research Council grades. Grade 1, patient is alert and oriented. This is usually early in the disease. They do not present with any focal deficit. In grade 2, if the patient has full sensorium but has a focal deficit, or if the patient has a low GCS less than 14 but more than 10, with or without a focal deficit, they'd be called grade 2. Once the GCS falls below 10, whether the patient has focal deficit or not, patient is in advanced stage of the disease, and this grading is important in prognosis and mortality. Coming to when we diagnose tuberculous meningitis, when we get a patient with a history of subacute or chronic meningitis, when we get MRI findings, when we do a CT, a contrast CT or a contrast MRI, MRI is better than CT, and we see these thick basal exudates, and which are mainly in the basal cisterns, along with tuberculomas, and patient may have hydrocephalus with opening of the temporal horns of the lateral ventricle and stroke. To diagnose TB, definitely we have to demonstrate Mycobacterium tuberculosis in the cerebrospinal fluid. CSF usually shows a lymphocytic pleocytosis with elevated protein, low glucose, and raised ADA levels. But if we want to see a definitive diagnosis, AFP smear positivity is seen in less than 20%, usually around the 10% cases, and more if you get a larger volume of CSF. Culture is the gold standard, but it is too slow to be clinically meaningful for us. And nowadays we're using the PCR-based gene expert studies, which have got a sensitivity of 28%, but we can go up to 72% if we use a larger volume of CSF and we use centrifuge CSF. Coming through a case study of a 28-year-old female who presented with a 2-month history of fever and headache. She had a right hemiparesis 20 days prior to admission, after which she had been seen outside. And she presented to us in the emergency with a focal seizure and altered sensorium for a day. On examination, she was drowsy. She had left face, arm, leg weakness. She was moving the left side less compared to the right. Both plantars were extensor, and she had neck stiffness. When we looked at her imaging study, you can see that she had thick basal exudates. She had multiple tuberculomas. She had an old infarct. She had that infarct in the left thalamus, and she also had a new fresh developing infarct within the right MCA territory. And you look at her angiogram, it is showing signs of vasculitis with stenosis and with signs of arteritis. Now we look at when we saw the CSF of this lady, she had a lymphocytic pleocytosis with elevated protein, a low glucose, and her gene expert was positive. She was rifampicin sensitive, and she was started on 4-drug ATT. She had been started from outside, anti-tuberculous therapy, and 15 days earlier, which we continued, and we added on dexamethasone and aspirin. When we look at the magnitude of the problem that is stroke in tuberculous meningitis, we see that almost 15 to 57% of patients with tuberculous meningitis have stroke. But we only see, in 20% of the patients, we can clinically see a focal neurological deficit. CT scan reveals infarctions in up to 35%, but MRI is more sensitive. We can see in just a little less than 60% of the patients, we may see a stroke. Autopsy studies reveal infarctions in almost 56% of TBM patients. And in a systematic review by Tsai et al., they found that the frequency of stroke in tuberculous meningitis was globally around 30%. So if we look at untreated tuberculous meningitis, it is uniformly fatal, and stroke increases the mortality in tuberculous meningitis by 3 times. So even with treatment, the mortality in TBM, once a patient has stroke, is almost 50%. Now, when we look at the pathogenesis, how stroke happens in TB meningitis, several mechanisms may contribute. All of these are more prominent in stage 3 of the disease. So we have these dense exudates which encase the intracerebral arteries, leading to arteritis or vasospasm. These exudates also cause hydrocephalus, which cause stretching of blood vessels and further vasospasm. It also is a hypocoagulable state with decreased protein C, increased factor VIII levels, and impaired fibrinolysis. And cerebral salt wasting may also lead to hypovolemia and hypoperfusion, worsening the hypocoagulable state. Now, if we look at the infarcts in TBM, they're usually pathologically secondary to a vasculitis. And these patients have 3 patterns of reported vascular pathology. The most common is the one where there's infiltrative, where the granulomatous exudates infiltrate or entrap the vessels in the subarachnoid spaces. The next is proliferative, where you have a granulomatous proliferative angiitis. And the third and the most dangerous is the necrotizing vasculitis, where you get dense inflammation in the vessel wall with endothelial proliferation in the lumen. When we look at various pathological changes, and we saw in an autopsy study in 51 tuberculous meningitis brains done by Chatterjee et al., they found infarcts in 37 patients out of 51. They found medium and small vessels most commonly affected, with the penetrating vessels developing end arteritis. Clinically, the focal deficit in tuberculous meningitis usually develops gradually due to the vasculitis, and the TBM-related stroke most commonly presents with focal weakness, maybe a monoplegia, a hemiplegia, or a quadriplegia. Now, the deficit definitely depends upon the location of the infarct. If you may get large strokes which add on to the raised ICP, which is already seen in tuberculous meningitis. Often strokes in TBM are difficult to diagnose because patients are already deeply comatose. Strokes happen mainly in stage 2 and stage 3. And pre-existing weakness may be there due to tuberculomas or arachnoiditis, and that confuses the picture. And many infarcts may be silent. In a study of TBM, in a study of tuberculous meningitis, among 12 patients with infarcts, 3 were silent. So MRI is definitely superior to CT scan for detection, especially of acute infarcts and for brainstem infarcts. And if we look at this picture, we see that in 75% of the patients, the infarcts located in the TB, they are located in the TB zone or the tubercular zone. So this includes the head of the caudate nucleus, the anteromedial thalamus, and the anterior limb and genu of the internal capsule. The arteries involved are commonly the medial striate, thalamotuberal, and the thalamoperforate vessels. Vertebrobasal territory is also involved in 20% of the patients. Now, when we look at the angiographic findings, we find that the main feature is a marked segmental narrowing and irregular appearance in the supraclinoid ICA, extending to the MCA and then the ACA. So the classic angiographic triad of tuberculous meningitis is a narrowing of the supraclinoid ICA, widely sweeping pericallosal artery or outward bowing of the thalamostriate vein, and delayed circulation in the MCA with scanty collaterals. SPECT studies also reflect cerebral blood flow changes, which can demonstrate areas of hyperperfusion even prior to the patient developing infarction. Coming to the treatment of TBM-related strokes, the treatment of TBM, the WHO recommends 4-drug ATT in anti-tuberculous treatment in drug-sensitive tuberculous meningitis with rifampicin, isoniazid, pyrazinamide, and ethambutol for 2 months, then the intensive phase, and then the maintenance phase of around 7 to 10 months with rifampicin and INH. We give dexamethasone in the initial 6 to 8 weeks. Dexamethasone has an anti-inflammatory effect and is effective in reducing basal meningeal inflammation and encephalopathy, but not in reducing vasculitis. So dexamethasone is given in a higher dose and for a longer period, 6 to 8 weeks, in patients who have stage 2 and 3 disease, started with 0.4 milligram per kilogram initially for the first 1 week, and then we taper it and make it oral after a month. It significantly reduces mortality without increasing the adverse effects, but it does not reduce the occurrence of focal deficit or prevent disability in the survivors. So then that comes to the role of aspirin, whether we should give aspirin as prophylaxis in tuberculous meningitis to prevent stroke. A randomized open-label placebo-controlled trial was done in our institute where some patients received 150 milligram of aspirin, and they found a trend towards reduced stroke incidence, but there was a significant reduction in mortality. Now, aspirin, as we know, has got antiplatelet and anti-aggregant properties in lower doses, which is why it was selected, and anti-inflammatory properties in higher doses. Patients who receive both aspirin and steroid had greater benefit in stroke reduction than those who received either aspirin or steroid alone, or those who received neither. A meta-analysis of 3 randomized controlled trials also showed a significant reduction in new onset stroke in aspirin group compared to the placebo, with a number needed to treat of 10, but there was no significant reduction in the mortality at 3 months. But since stroke increases mortality in tuberculous meningitis by 3 times, there definitely is a significant mortality benefit. So coming to the important question of whether we should thrombolize a tuberculous meningitis patient who presents to us with an infarct, or if an infarct develops in the ward, what do we do? Current guidelines for ischemic stroke in the setting of infective endocarditis, we do not give alteplase because of the risk of intracranial bleed. And the high rate of bleeding is because of concurrent mycotic aneurysms, microabscesses, and arthritis. Now, similar findings are seen in tuberculous meningitis with necrotizing, infiltrative, and proliferative vasculitis. Also, we see that stroke in TBM is not quickly diagnosed because patients are already comatose. Many of the infarcts may be silent, or patients may have pre-existing weakness. So we usually do not thrombolize these patients. Coming to the rarer forms of stroke, that is intracranial bleed, it is rarely reported, but reported definitely in tuberculous meningitis, usually associated with tuberculomas. Microhemorrhages are seen due to disintegration of the internal elastic lamina of the vessel walls and rupture of small mycotic aneurysms. Coming to cerebral venous thrombosis, it's rarely reported, but if reported, it is precipitated by vascular endothelial injury, sluggish venous flow, and tuberculous meningitis being a prothrombotic and hypercoagulable state. There's a higher risk in patients, in women who are on oral contraceptives or who are postpartum and develop tuberculous meningitis. They are more likely to develop cerebral venous thrombosis. Coming to the prognosis of untreated TBM, we know it is uniformly fatal, and even with good treatment, mortality is 4 to 50%. So now this depends upon the BMRC stage. When the patient comes with stage 1 disease, it's a 4% mortality, and with stage 3 disease, you can see that it's almost going up to 50%. So risk factors for poor outcome in tuberculous meningitis are delayed diagnosis and treatment, advanced disease, drug resistance, and stroke. So with treatment, mortality in patients with TBM-related stroke is 22%, and poor outcome is almost 55%. So summarizing the talk, we see that tuberculous meningitis is the most dreaded complication of tuberculosis. 15 to 57% of patients with TBM have stroke. Stroke increases the mortality and morbidity of tuberculous meningitis. Stroke in tuberculous meningitis is due to the dense exudates, which causes arthritis, vasospasm, and stretching of vessels with hydrocephalus. Stroke in the tuberculous meningitis is most commonly seen in the tubercular zone. Always watch patients with TBM for new focal deficits and clinical worsening, especially in stage 3 and stuporous patients, and consider a new stroke which has developed. Aspirin and steroids have a role in stroke prophylaxis in tuberculous meningitis. Always remember that all focal deficits in tuberculous meningitis are not due to stroke. Patients may have focal deficits due to tuberculoma or arachnoiditis. It is important to diagnose TBM early because advanced disease, drug resistance, and stroke are predictors of poor outcome. Thank you.
Yeah. Thank you, Dr. Vinita Daniel, for giving us an excellent overview of CNS tuberculosis in its various forms, how it can lead to stroke, both arterial and venous, and also about hemorrhage. Thank you for highlighting the importance of early diagnosis. We know if we treat them in the stage 1 and stage 2, they have a better prognosis and we can prevent strokes. And also sharing about the latest information about aspirin antiplatelet therapy along with steroid, how it can reduce the incidence of stroke. So thank you very much. I request all the participants, if you have any questions, please post it in the Q&A box. So let's move on to the next topic, which is an uncommon infection that can affect the brain, that is neuromelioidosis and the brain. And Dr. Angel Miraclin, who's a consultant at Christian Medical College, Vellore, and she's going to speak to us about this an uncommon infection, neuromelioidosis. Over to Dr. Angel.
Good evening to everyone. At the outset, I would like to thank Dr. Jeyaraj, sir, for having given me this opportunity. And also, I would extend my gratitude to Dr. Sanjit and Dr. Ajit Sivadasan, professors in the department, for giving me the support to present in this webinar. So going on to this neuromelioidosis, so I would start with a case vignette. This is a story of a 32-year-old homemaker who presented with history of fever, headache for 5 days, vertiginous sensation with ataxia for 4 days. She also had deviation of angle of mouth to the left with slurred speech and double vision for 2 days. So going by the timeline, somewhere around 9th December, she's underwent a tooth extraction, after which she was well for about a week. She develops fever, headache, goes on to develop all signs associated with the brainstem dysfunction. By the time she came to us, she was altered, she was obtunded, and she was sick. So coming to the relevant history of exposures, she had multiple exposures. She had gone for a family trip to a famous temple. She had a dip in the pond. She had a history of travel to a resort. She also has a small vegetable garden. She does a lot of gardening as well. There's no history of any consumption of meat, exotic meat, or any substance abuse. On examination, when she came to us, she had a very low GCS. Pupils were bilaterally pinpoint. She had no brainstem reflexes in the form of absent extraocular movements. And this is what her imaging showed. So if you actually see, there's a lot of diffusion restriction, which is seen at the level of the middle cerebellar peduncle, which is involving the brainstem. And the post-contrast scans actually pick up these small ring-enhancing lesions, which are probably evolving abscesses, which you can see at the brainstem as well as in the cerebellum, middle cerebellar peduncle. So coming to the investigations, she did have high counts. All the other organ systems were normal. We sent 4 blood cultures, which were negative. She did have some cells in the CSF. But again, CSF culture, including a 16S RNA, was negative. Chest X-ray has some infiltrates, probably because of aspiration, but ultrasound exam was normal. So we didn't know what she had at the beginning. So we started her on meningitic dose of Miro, Vanco, acyclovir. She was ventilated. She did require some inotropic supports, but she continued to have her low score and with absent brainstem reflexes. There was some twist in the tale when the husband who was initially giving the history was waiting outside the ICU, and he developed some low-grade fever and developed a sudden onset right facial weakness with gait imbalance and slurred speech. And he was immediately shifted from the waiting area to the ED, where he dropped score. He was intubated. And surprisingly, his imaging also showed a very similar picture to the wife. So that is when we were thinking, okay, we're dealing with an infection, but we're not unsure what the infection was, because his investigations all were normal as well, and all the cultures were negative. Finally, we decided to do a brain biopsy, and the PCR from the brain tissue for the spouse was positive for Burkholderia pseudomallei, and the cultures also subsequently grew. Burkholderia pseudomallei. We started her on meningitic dose of meropenem. We added on cotrimoxazole doxy. She gradually improved. Currently, she's at home, quadriparetically dependent for all ADLs. However, the husband succumbed at the 32nd day of illness. So coming to neuromelioidosis, it's a very uncommon infection world through, but we are seeing it of late at a high numbers in the endemic countries, which are the tropical countries. So it's an infectious disease caused by soil and water bacterium. So mostly skin inoculation is considered the main route, where agricultural workers, because it's a soil bacterium, when they walk in the paddy fields or in the fields, the bacteria get inoculated in the skin, and it becomes, it goes along the bloodstream. It's hematogenous and seeds multiple solid organs. Recent evidence, much of evidence comes from Australia and Thailand, where even inhalation occurs during extreme weather events. Because it's a soil bacterium, when there is a high amount of rainfall, it aerosolizes the bacteria, and when you inhale, you get pulmonary melioidosis, as well as you get ingestion of contaminated water, which can actually go to the gut. It can cause gut ulcers, as well as it can cause hematogenous disease. So high-risk groups are the patients with diabetes, those with chronic kidney disease, and also have alcohol abuse. So if you see this map, if you actually see the endemic countries, if you see, India is actually fully in red. There's a complete presence of this bacterium all throughout. Whereas a lot of other countries, which are predominantly in the Southeast Asia and Australia, have very high burden of melioidosis. So coming to what are the other manifestations they can have chronic ulcers, you can have pulmonary melioidosis, it can have chronic cavitating pneumonias, you can have abscesses, like in the solid organs, you can have splenic abscess, liver abscess, skin lesions are also reported. These are all part of the hematogenous dissemination. From somewhere it gets inoculated, it goes along the bloodstream, disseminates and causes disease. But what is striking about neuromelioidosis is it can either, because of hematogenous spread, and now we also know that it can go along the nerve endings. It is neurotropic and it can spread along the nerve endings and reach the brain. So compared to all the other forms of melioid, CNS melioid, patients with CNS melioid are less likely to have predisposing risk factors, and they have a very wide incubation period, ranging from 1 day to even 150 days. So it's not necessary that you have an inoculation today, you'll develop the disease within a week. It can just stay on for some time and then develop later. So this is from our own center, where we had initially published about 14 cases, for all of them, most of them presenting with abscesses, some with scalp collections, some with automastoiditis, but we did not see primary neuromelioidosis. Most of them are because of hematogenous spread. So this was one interesting animal study from John et al., where they actually did an experiment where they took mouse and they actually inoculated in the nose, or they smeared it in the nose, like inhalation. And they found that both actually set up a clinical infection. And they found that as they sectioned the olfactory nerves, as well as the trigeminal nerves, they could actually find the bacteria within the nerve fibers. So this experiment actually showed that compared to just intranasal inhalation, if you inoculate subcutaneously, if you have an inoculation, the chance of you developing an infection is higher, with a higher fatality in the mice. So this is one more thing, what we see in neuromelioidosis, what is called as the tunnel sign, where because of this neurotropism, the bacteria tends to spread along the nerve fibers. If you see the first image, you can actually, and the second image, you can actually see it going along the corticospinal tract and causing a diffuse cerebritis. So this is the corticospinal tracts which are lighting up. And here you see the internal capsule lighting up. So it actually goes along the nerve, which is described as the tunnel sign. This is another important finding, which you see. There's enhancement of the cranial nerves because your trigeminal nerve endings in the face, in the nose, in the mouth, and the facial nerve endings end in the brainstem. So if you see here, it sets up the cranial nerve nuclei, lights up, and the entire trigeminal nerves is actually thickening and it's enhancing. They ultimately sit there and they form abscesses, and these are all the micro abscesses. They break down into big abscesses, and they can go up as well as down as myelitis. So this is our recent work, thanks to ICMR, National Institute of Epidemiology, Chennai, and the Directorate of Public Health, Tamil Nadu. Our department, along with them, did a outbreak investigation where we actually looked at 21 cases, which presented over a very short span of 6 months, from a particular clustering to a particular district near a hospital. And we found that about 10 of them had preceding dental procedure, and we were able to trace the source of infection from one particular iatrogenic focus in the dental clinic. So this was our case vignette, which I shared with you in the initial presentation. But we were left with some important, intriguing questions. So is it a new strain Because previously all we used to see was septicemic melioidosis, why are we seeing increasing primary neuromelioidosis? Or is there any change in the bacteria which is causing more neurovirulence? And apart from India, where are these strains circulating? So then we came up with this interesting, we found this interesting article from Australia where they found that this BIM-ABM allele, which is a mutation which is present in the bacteria, contributes to more primary CNS melioidosis. Presence of this particular allele can have more brainstem involvement, and they have much more higher virulence and clinical severity. So we have our own surveillance system. For the last actually 20 years, we've been collecting all surveillance samples of melioidosis blood culture as well as other tissues. So we actually constructed this phylogenetic tree. So just to keep things simple, if you actually see, the ones in the yellow are all the surveillance isolates which we collected over the last 10 years. And the ones in the red are the ones which we had it in the outbreak. And the ones in the green are the contextual isolates. That is, during the outbreak, we had other patients who were presenting during the same time. And we found that our strain was, all the 3 outbreak strains were similar. It was ST1553. And if you see the last circle here is the BIM-ABM expression. So if you see, only India and Australia actually has this BIM-ABM expression, and all the other countries do not have it. So that explains why we are seeing more neuromelioidosis, which is primary. And it's very interesting to see that there was one published report in NEJM, another unusual outbreak, where they actually reported multi-state outbreak of melioidosis from 4 different distinct patients from scattered areas in Texas. US is not endemic for melioid, so it has to be acquired through travel or some other form. So when they investigated, they found that all 4 of them were using a particular aromatherapy or a component of a room spray. And in fact, in our phylogenetic tree, this is the aromatherapy related outbreak strain, which was clustering along with the Indian isolates. Then we found out that this aromatherapy bottle was actually imported from India. So probably the bacteria reached US through that way. So these are, and this investigation was done in our lab. With kind permission from Professor Balaji from clinical microbiology, who helped us sort out this investigation. So what is the relationship? Why am I discussing this in a stroke webinar? So out of these 21 patients we saw in the outbreak, so 5 patients were actually, the initial impression was a posterior circulation stroke. So it could be a stroke mimic. So in endemic countries where these unusual, pathogens exist, it's very important, like how the previous speaker highlighted, TB can present as a stroke. Similarly, neuromelioidosis can mimic a stroke like a brainstem syndrome. So it's very important that we know these classical radiological picture and the presentation. So how do we manage? We have, management is very difficult. However, in our center, we have actually standardized management with high-dose meropenem, and we use therapeutic drug monitoring. We actually frequently check the levels and adjust the doses accordingly. And we also go through eradication therapy, which has to be given longer. So when it comes to neuromelioidosis, the duration for intensive phase, it's actually 8 weeks. In fact, we've had patients we've continued up to even 4 months, and they've done well. And those patients who we did therapeutic drug monitoring and we used steroids have actually had better chance of improving than those without. So concluding, we have a highly neurovirulent strain of Burkholderia pseudomallei in Southeast Asia. It's neurotropic, and direct inoculation or inhalation can cause transneural spread to brainstem. So we need to be aware of the clinical manifestations and characteristic findings. And we should also enforce rigorous infection prevention control practices in healthcare facilities, because any form of inoculation and you irrigate with contaminated fluids or contaminated solutions, you can catch the infection. So that's our institution here, and thank you for this opportunity.
Thank you, Dr. Angel. So fascinating. The infection, which is uncommon, and if we are not aware, definitely we can miss, particularly the initial presentation of multiple ring-enhancing lesions, brain abscess, and we can really get carried away that it's probably a brain abscess. And thank you for showing the typical neuroimaging findings of that tracking. And so those are some of the features that will really help us to differentiate. Of course, it is a stroke mimic. We all have to be aware when we are dealing with these type of patients. And thank you very much. Let's move on to next speakers. Again, another infection of the CNS, Chagas disease and stroke. I request Dr. Jamary-Filho, the Professor of Neurology from Federal University of Bahia, Brazil. He will take over this session. Yeah.
Thank you, Jeyaraj. Well, I want to thank the World Stroke Organization and Dr. Pandian for the kind invitation. Learning a lot today with the other speakers, different diseases. And I want to switch gears to Chagas disease, which differently from the other diseases that have been discussed, more frequently than not, the patient does not know he has Chagas disease when he suffers a stroke. So that's a main difference, which you'll see will change our management. I have no conflicts of interest. And this is the classical teaching in medical school, where it's a disease that affects 8 to 10 million people, mostly concentrated in Central and South America. 30% of patients with Chagas disease will develop a cardiac disease, and most cases of stroke are thought to be due to cardioembolic mechanism. However, there are two different things that I want to emphasize with you that are wrong about the classical teachings in medical school. One of them is that now Chagas disease is a global disease and has been reported in many countries in the world, and mainly due to immigratory patterns. In the United States alone, for example, there are over 300,000 cases of Chagas disease. And the other common misconception is that it's always due to cardioembolism, and you'll see during the lecture that it's not the case. Many patients are asymptomatic and develop a stroke. So learning objectives today are to identify Chagas disease as a cause of stroke, to determine if the likely mechanism in Chagas-associated stroke, recognize other neurologic manifestations of Chagas disease, which are also present, and finally, how to manage these Chagas-associated stroke cases. So this is the classical teaching. There's a triatomine bug, which harbors the parasite, which is a Trypanosoma cruzi. It infects usually children, and 20, 30 years later, patients may manifest in 30% of cases a cardiopathy. And this activation of the immune system is probably related to this. And these are the muscle fibers of the heart, and intermingled within the muscle fibers are the Trypanosoma cruzi amastigotes. In pathological specimens, you can see that the more typical finding is the apical aneurysm and thrombus. If you look histologically, there are a few parasites here actually, and this is mainly due to the conduction system involvement causing dyskinesia in the left ventricle and thinning of the apex, which is a relatively preserved part of the myocardium. And these patients will have embolic stroke even though they have they may have few symptoms from the heart, because they might have normal ejection fraction and embolize before they develop overt cardiac disease. Infection has really been related to stroke, even though despite the other mechanism that has been discussed today associated with vasculitis, but infection itself activates thrombosis. And if we try and fit that into the classical finding of classical classification of stroke, which is mainly anatomical, we see that infection fits into each of the classical classifications. So if we look at the large vessel strokes, which are due to a carotid or vertebral artery atherosclerosis, There have been reports and association of infection increasing atherogenesis, increasing microthrombi. In case of Chagas disease, most cases are thought to be due to this mechanism of cardiomyopathy development and left ventricular thrombus. And in the cases where no anatomical abnormality is found, inflammation is thought to directly affect the thrombosis system, the inflammatory and thrombosis system leading to thrombosis. The previous lecturers, they showed basically cases where there was evidence of infectious vasculitis, evidence of thrombosis in the setting of acute infection, but the role of chronic inflammation is probably more relevant in Chagas disease. Similar models of other diseases have also shown the same association. So infections with Helicobacter, chlamydia, even periodontal disease have been associated with increased stroke risk. And obviously in the recent pandemic of COVID, this was also the case of both arterial and venous thrombosis. Our group and others have also shown that in patients who don't have cardiopathy or have mild forms of cardiopathy, just the Chagas disease serology is a risk factor for stroke development. And when we look at survival curves of stroke and death, Chagas is associated with a 2.5-fold increased risk of stroke and almost a 2-fold increase of death. With a rate of around 2% per year of stroke, independently of whatever antithrombotic regimen you're on. Okay. There is a publication from 2023 and from the US, 429 patients followed with dual positive T-Cruzi antibody positive. And the cardiomyopathy risk was 1.3% per year, and the risk of stroke was around 1% per year, which is pretty similar to the other cohorts that we've cited. Switching to management, the acute management, differently from the other diseases we've heard about today, there have been reports of thrombolysis benefiting these patients. The first publication here was just an N of 2, so no further comments on this case series. But in the second publication, there were actually 24 Chagas patients compared to 150 non-Chagas patients, all thrombolyzed. And these 24 Chagas patients had similar efficacy and safety rates for thrombolysis. So we do give thrombolysis in patients who have known Chagas disease and develop an acute stroke. In the secondary prevention realm, there's this recent publication by a collaborator of ours from Minas Gerais in Brazil, where there are a few interesting observations. One of them is that there is a high recurrence rate despite anticoagulation in this cohort of patients with cardiomyopathy, with Chagas disease cardiomyopathy. In this particular patient population, transthoracic echocardiography fares better than transesophageal echocardiography. And this is a very interesting observation because the hallmark of the disease is an apical aneurysm with thrombus, and the apex is better seen in transthoracic echocardiography than transesophageal. In this particular patient population, the predictors of recurrence, the most significant one is the left ventricular dysfunction, so the left ventricular ejection fraction, but also high left atrial volume and the presence of left atrium, left ventricle aneurysm, and left ventricular thrombus, as shown here in the image. In patients who don't have overt cardiac disease, we underwent a study and published this a few years ago, looking at patients with embolic stroke of undetermined source. So these are patients who have normal arteries, normal heart on echocardiography, and we performed cardiac MRI in these patients and found an embolic source in 26%. So for 1/4 of the patients had findings like apical thrombus with aneurysm. This is the way the heart beats with akinetic and dyskinetic ventricle wall motions. And in this particular case series, Chagas disease and coronary artery disease were predictors of having abnormalities in cardiac MRI. So currently what we do in Brazil is if a patient either has Chagas disease or coronary artery disease history, and we have not found another source of cardiac embolism, we perform cardiac MRI. So the management of Chagas-associated stroke in terms of secondary prevention, we first try and rule out cardioembolic source, and we prefer the transthoracic echocardiography for that respect, perform 24-hour Holter. In Chagas, most of the arrhythmia is ventricular, not atrial. So atrial fibrillation is actually not frequent in this patient population, but does occur, 2 to 5% of patients. And when this first evaluation is negative, we perform cardiac MRI because we know that the positivity is greater than in the other diagnostic tests. If we find the cardioembolic source, anticoagulation is usually started with warfarin, and there's also limited evidence that DOACs might be effective in this patient population. If no cardioembolic source is found, we usually use aspirin as first-line treatment. What we don't know is if targeting systemic inflammation would be effective, and certainly further studies would be warranted to test this kind of hypothesis. Especially because stroke is not the only manifestation in this chronic patient population. So we have done work, and this is an old publication of ours, seeing this kind of pattern of brain atrophy in patients with Chagas disease as compared to control patients. And this is a case, these are just two examples, but this happens if we look at the population level. And we did not know what is the clinical repercussion of this finding until recently. And this is a publication we just did this year, where we studied 518 patients with Chagas disease and found and looked at Chagas as an exposure, and were able to adjust for the main confounders of cognitive change, such as age, sex, educational level, and LV ejection fraction. And what we found here was that almost a little more than 1/4 of patients had evidence of cognitive change, mostly in memory and visual spatial domains. And this was validated in the multivariable model, where global cognition was 90% more common in Chagas patients, where in comparison to the control population, mostly due to visual spatial dysfunction. What do we do with these patients? So patients who are asymptomatic basically, but have complaints of cognition, we don't know. The only work looking at anti-parasitic treatment in Chagas disease is this clinical trial published in 2015. Using besnisadol for Chagas cardiomyopathy, and it did not reach the primary endpoint of cardiac endpoints, but did not look at cognition as an endpoint in the clinical trial. So we do not know. So this is the current proposition that not only Chagas disease causes embolic stroke. This is probably the main mechanism in most cases of ischemic stroke that we see, but we have to be aware that there's a secondary pathway where patients might have stroke and brain atrophy without requiring the overt cardiac disease. So in summary, there's a high suspicion rate that's necessary in these Chagas disease patients for stroke, especially if they're young immigrants or travelers to endemic areas. And identifying the most likely stroke mechanism helps to define the treatment strategy. What we usually do is to anticoagulate cardioembolic stroke, antiplatelet medications for non-cardioembolic strokes, but we do not know whether this pathway here can be blocked. And certainly new studies would be warranted here to look at this pathway if it requires blockage. And one last awareness is that we should be aware of non-causal association in endemic regions because frequently patients with Chagas disease are also hypertensive, diabetic, dyslipidemic, so they might have lacunar stroke, other concurrent mechanisms that are not due to Chagas disease and should be just treated likewise. So thank you for your attention.
Yeah.
And I think we'll be moving on to the questions part. Thank you so much.
Yeah. Thank you very much for an excellent overview of Chagas disease and stroke, and particularly the mechanism part. And we all need to be aware because of the travel and the immigrant population, endemic areas exposure. So we need to be really taking a good history, particularly a patient with cardioembolic stroke. There's a thrombus, and we don't know, what is the actual cause. And so thank you for highlighting. And we will have a Q&A. So Dr. Vinita Mani had answered some of the questions, but for the sake of the other participants, maybe Dr. Vinita, you could comment on a question. How would you comment the possible cause of stroke in a young patient with TB meningitis, untreated HIV infection, and concomitant PFO, patent foramen OLA?
Yeah, that's a deadly combination. The patient has HIV, and he also has developed tuberculous meningitis. Now we know that patients who already are living with HIV/AIDS, when they get tuberculous meningitis, they have a very high mortality. Even with treatment, mortality goes up to 60%. The stroke chances are because of the TBM, because of vasculitis and the other causes. But if the patient has a patent foramen ovale, of course, that could be if the patient has other causes for stroke. I think, yes, the patient has a very high chance of stroke in that case and should be given aspirin.
Yeah, I think one other imaging finding that would be of help is the topography of the infarct in PFO and TBM, the basal ganglia, the tuberculous zone versus the usual cardioembolic territories, the large arteries which are involved, and so that could give some information based on the MRI. And there is a question on nimodipine in patients with TB meningitis to manage vasospasm. You want to comment on it? And
we have never used nimodipine in vasospasm due to TB meningitis because usually the cause of stroke is because of a vasculitis. But they have tried nimodipine in some patients who have got, there have been reports of nimodipine being used in pyogenic meningitis. But in tuberculous meningitis, I don't think so. It has been used. And it's mainly dexamethasone and aspirin which have been used in this.
yeah, so there are a couple of questions on prevention of stroke in TB meningitis. I'll just club all this. One is the role of aspirin to prevent this stroke in TBM. Number two, are there established screening protocols to prevent stroke in TB? And if we should, what should be standardized to prevent? So prevention, one is aspirin, another one, are there any specific standard protocols?
To prevent the vasculitis, it's usually the dexamethasone which is used. When the patients come, we give dexamethasone in the dose of 0.4 milligram per kilogram. In the first week, then we reduce it to 0.3 in the second week, then 0.2 and 0.1. in the 4th week, and then we put the patient on oral steroid, which we taper over the next 4 weeks. So usually around 8 weeks in stage 2 and 3. And if the patient comes in stage 1, that is, the patient does not have any stroke or focal deficit, we still give dexamethasone, but at a lower dose, 0.3 milligram per kilogram. And then we, after 2 or 3 weeks itself, we make it oral and give it for another, taper it over another 3 weeks. So 6 weeks in patients who have stage 1. And aspirin we give in all patients, even if they come in stage 1 tuberculous meningitis. As for screening protocols to prevent stroke, every patient with tuberculous meningitis should receive dexamethasone and aspirin, and they anyway get an MRI at the time of diagnosis. Contrast MRI is highly sensitive in picking up infarcts. Even silent infarcts can be picked up.
Okay, I think let's switch gears. Let me go to neuromelioidosis. There's a question: without brain biopsy, can we diagnose any serological investigation? Yeah.
So, yes, thank you for the question. So, unfortunately, the serological tests are not neither they are sensitive or specific. And especially in endemic countries where you can have even high degree of false positive results because it's a ubiquitous organism. So the best yield is from the tissue itself. So that's why it's impractical to do a brain biopsy for everyone. And that's why even in our series of 21 patients, we've had just 5 patients who we had a microbiological confirmation. And among the 5, 3 were from the brain. So 2 were brain biopsies, 1 was from the abscess in the brain. So that is, so that's why it's very essential to know how they present and the radiological features. So the tunnel sign and the way the location of the lesions and the exposure carries a much more added advantage than a microbiological confirmation.
Yeah, thank you.
Thank you, sir.
So there's a couple of questions on TB, and then I'll just maybe to conclude something on Chagas as well. How long to give aspirin? That is one question. I think a couple of people have raised. There is a question that we don't have still good evidence based on meta-analysis whether to give aspirin. Dexa, of course, we have. So duration of aspirin, what do you think, Dr. Vinita?
So we usually give aspirin for the duration of anti-tuberculous therapy. The WHO, they say that we should give therapy for about a year if the patient is having tuberculous meningitis. But we have seen many patients relapsing by giving after 1 year. So we usually continue for at least 18 months to sometimes even 2 years. And as long as the patient is having the anti-tuberculous treatment, we continue the aspirin. And usually when the basal exudates and all resolve, after that, the risk of strokes significantly reduces. So actually, we have never stopped the aspirin at around 6 to 8 months, after which the basal exudates, they consolidate into tuberculomas or they disappear. So, but we have usually continued it for the duration of ATT, that is around 18 months to 2 years.
Yeah, thank you. So, Dr. Jamary, just a question from my side. The thrombus that we see, in Chagas disease, does it disappear with anticoagulation because it's a parasite induced? So, how long do you continue that?
So yeah, it's actually an interesting phenomenon because if you look histopathologically at the apex, which is the place where most frequently you find the thrombus, there are actually no parasites there. So what usually occurs is that the Chagas conduction system, the ventricle becomes so dyskinetic that it contracts and the vector of force affects the apex of the heart, thinning the myocardium and causing either aneurysm or just direct thrombus formation. So it really behaves more like thrombus induced by low flow in that region. and it does respond to anticoagulation. So either warfarin or also DOACs have been reported to induce thrombus dissolution. And if you do like if you follow the thrombus over time, we've seen patients like 30 days of anticoagulation resolve the thrombus and it goes away. Yeah, it goes away. So it's
and yeah. Another information is about the cognitive decline in these patients. Are they due to silent infarcts or some other mechanism that leads to cerebral atrophy?
So yeah, we the straight response is we don't know. We are studying this currently. So we have a large cohort in my region where we are performing MRI in these patients, and our initial impression is that it's not due to embolic infarction in patients who have no history of stroke, obviously. So patients who have a stroke history, they might have dementia due to the stroke, so vascular dementia. But in patients without a history of stroke, they still develop neurological decline, and that's mostly due to the atrophy we see in these patients that's accelerated in comparison to patients without Chagas. Yeah.
Yeah, thank you. I think we will conclude with few more questions on tuberculosis. Okay, so there are a couple of questions on the infarct location and TB and stroke. No, if it is outside the TB zone, can we clearly say that it is related to tuberculosis? Dr. Vinita, yeah.
The tubercular zone is the most common site for the tubercular infarcts, but that doesn't mean that you do not get infarcts outside the tubercular zone. We also see large MCA infarcts in some patients. We see vertebrobasilar involvement, which are usually very small microinfarcts. We see small infarcts in the brainstem as well. And in patients who have comorbidities, like elderly patients who are developing TB meningitis, they may have other comorbidities like diabetes, hypertension, homocystinemia. So these patients, they also tend to develop, they may even have LVOs associated with tuberculous meningitis.
Yeah, there is an interesting question about statin neuroprotective treatment. The statin, which has some anti-inflammatory effect. And there is a question on neuroprotective treatment. Are there any drugs that can be given for these patients besides dexamethasone?
Statins have not been used. I don't think statins have ever been used for these because it's mainly a vasculitis rather than an atherosclerosis which is forming. Also, I think they would interfere with when you're already giving highly hepatotoxic drugs, they might add on to the toxicity without any extra additive role, though it has anti-inflammatory action as well.
Yeah. I think one last question I just asked Dr. Angel, and then we can conclude. It was very interesting to see the Australia and India in terms of the profile of the agent, and so what do you think? I saw the report that is primarily from the indigenous population. Is that correct, from Australia?
Yes, sir. So basically, Australia, it's more of the northern Australia. That's where Darwin, all the guidelines for melioidosis actually comes from the Darwin registry. So what they, they are also reporting a lot of primary neuromelioidosis. So initially what we were seeing were because of hematogenous spread to the brain as a part of bacteremia, and then it seeds the brain. But of late, this has actually enlightened us about this unique presentation. And after this outbreak, we're regularly seeing cases. In a month, we at least have 1 or 2 patients admitted with this. So this BIM-ABM, this is the mutation which is seen in our population, which is also expressed in Australia. So we took all the other strains from, publicly available database genome sequences from Thailand, Vietnam, Sri Lanka, US. None of them have it. None of them have this BIM-ABM allele. But at the same time, another interesting thing is even our septicemic melioidosis patients have the allele. So it's not just, you cannot completely say that it's only BIM-ABM which is contributing to neurovirulence. But why only us in Australia are seeing this is another intriguing factor. There was one thought in Nature reviews where they said that these migratory birds, which actually, they migrate transcontinents. So they actually sit on these marshy areas, so the swamps. So actually, why it's only in the northern Australia, which is facing us. So whether these birds can be implicated because they're actually nesting in those marshy lands is another thought. So a lot of questions still remains.
It's very interesting. Yeah. There were some questions on children and TBM. It's almost similar. I think Dr. Vinita had already answered. So I think it's a great session that we had. Interesting mechanism, imaging findings, and it's a global cross-continental, how climate change and migration, not only human beings, but birds also would be implicated in some of these infections. So it's a great session, and thank you very much for all the speakers for your contribution. Over to Laura. Yeah.
Thank you very much. We'd like to thank, on behalf of the World Stroke Organization and the World Stroke Academy, all of you for participating, but especially our speakers and our moderator for their time, for their excellent talks. We are not resharing the poll about the level of awareness because I think that the questions and the chat already clearly showed us that a lot was learned today, which is great. This is what we want to achieve. Just a quick reminder from my side that our next webinar is taking place on August 18th. We will be discussing Moya disease, so another rare progressive cerebrovascular disorder which has significant clinical implications. So if you want to learn more about it, please join us on August 18th. The registrations are open. And talking about registrations, we want to extend also our invitation to the World Stroke Congress happening this year in Barcelona, Spain, from October 22nd to October 24th. This is the 17th Congress of the World Stroke Organization, and there are still early bird rates until August 5th, so you can go ahead and get your ticket. We hope to see you there. We hope to see you in our next activity, and thank you for being with us today. Take care.
Yeah. Thank you. Bye-bye. Yeah. Bye.
Thank you.
Very much. Thank you.
Thank you so much. Learned a lot today.
Yes.
Bye-bye.
Thank you for your lovely talks.
Take care.